Good evening. This is again Professor Nick, and today is March 1st, 2022. It's about 9:30 p.m. We'll review endocrine chapter for pediatrics. This course is designed for PAs and MPs board review exams. Let's talk about first, on the first slide, we'll talk about IDMs or infants of diabetic mothers. Here we have a sample question. 10.5-pound infant is born by a mother with type 1 diabetes. Upon examination of the newborn, he is shaking and hoarse systolic murmur is heard over the precordium. The baby right arm is abducted and internally rotate. His lab's finding shows elevated bilirubin. The question here is, what is the most appropriate next step of management? And we have A, IV insulin, B, blood sugar level, C, serum calcium levels, D, serum TSH, and E is CT head and neck. The right answer here is B. And this is like that because of the infants of diabetic mothers, or IDMs, are born microsomic with plethora, and they can be very jittery. The newborn usually has dramatically high circulating levels of glucose, but upon delivery, maternal glucose is no longer available. This child is still producing high level insulin, and thus his blood sugar levels are dropped. Cardiac abnormalities are common, as in this child, the most likely he has VSD by the description of the cardiac murmur. When we think of diabetes, our first thought is insulin treatment, or B. But this is the most common wrong answer. I'm sorry. Since it would further exacerbate these newborn problems. So the right answer here is B, blood sugar level. Another important clinical fact that in congenital adrenal hyperplasia, 90% or more of the cases are due to 21 hydroxylate deficiency. Let's go over the findings of IDMs. The first one is A, macrosomia. It means a large head. With macrosomia, all the organs are enlarged except the brain. So macrosomia means enlarge all the organs of the newborn. An increased output from the bone marrow leads to polycythemia and hyperviscosity. Here the child is described that he has possible shoulder dystocia, and brachial plexus palsy can be also in the history. B. This is a small left colon syndrome. Congenitally smaller descending colon lead to distension from the constipation. It can be diagnosed with barium study and treated with smaller and more frequent feeds. C, this is a cardiac abnormality. This is a major cardiac change in IDMs is asymmetrical septal hypertrophy due to obliteration of the left ventricular lumen, leading to decreased cardiac output. It can be diagnosed with EKG and echo and treated with beta blockers and IV fluids. This is renal vein thrombosis. Renal vein thrombosis presents usually with flank pain and possible bruit, which can be appreciated on auscultation, also with hematuria and thrombocytopenia. And the last one, this is metabolic findings and effects. The child can have hypoglycemia or seizures, hypocalcemia, which presents as a tetany or lethargy, hypomagnesemia, which can present with hypocalcemia, and PTH could be decreased. And the last one, this is hyperbilirubinemia, which is presents as an icterus or cairn icterus. Sorry for my accent. Let's go to slide number 2. Let's discuss here so-called CAAH, which is congenital adrenal hyperplasia. Basically, CAH is inherited defect of the steroid synthesis, which has 3 forms, which are 21 hydroxylase, 17 hydroxylase, and 11 beta hydroxylase. The clinical presentation is the most common presentation. It is a hypotensive child with severe electrolyte abnormalities. Also, the genitalia are ambiguous in girls. In boys, they don't initially exhibit any abnormalities, but then in the beginning they lose their defining sexual features as they age. Inappropriate facial hair, virilization, and menstrual abnormalities are also seen. And C, hyponatremia, hypocalcemia, hypoglycemia, and hypercalcemia also result in decreased aldosterone and cortisol production. This also results in acidosis due to hydrogen ion retention. The diagnostic test at birth, this is by serum electrolytes and increased 70-OH progesterone levels. On this table, on the right upper side, we can see the pathway of the cholesterol, which transforms to pregnenolone, which is then going in 2 directions, progesterone and 70-OH pregnenolone. Progesterone transforms to deoxycorticosteroid, then corticosteroid, then aldosterone, and 17-OH pregnenolone transformed to DHEA, and then to androsteroid. Then 70-OH pregnenolone transformed to deoxycorticosterol, and then the cortisol. DHEA EA transformed to androstenedione and estrone, then androstenedione transformed to testosterone, and then to estradiol. So here we have three options: 79 hydroxylase deficiency, 21 hydroxylase deficiency, and 11 beta hydroxylase deficiency. Basically, the treatment of all these complications are by fluids in electrolyte replacement, along with lifelong steroids for maintain sufficient levels of mineralocorticosteroid and glucocorticosteroid. Also, we need specific psychiatric counseling to aid with the gender identity issues. Let's go to the last slide. And here we have a clinical example for 2-year-old girl, which is from England, brought to the United States for routine visit. The parents state that they are worried because their daughter appears to walk abnormally and falls a great deal when she tries to play with her older brother. The child delivery is unremarkable. The parents state that she does not like milk and withdrew from both breastfeeding and cow milk quite early. The physical exam revealed very unsteady gait and bowing of the tibia, and X-ray revealed padding of the ribs and genius varus. Here the question is, what is the most likely diagnosis? We have A, rickets, B, cartilage syndrome, C, coarctation of aorta, D, traumatic fracture, and E, cerebral injury. The right answer here is A, because of the following reasons. Vitamin D deficient rickets is the disorder which is caused by lack of vitamin D and calcium. This child risk factors include living in a sunless environment and low milk intake. The child displays classical signs including rachitic rosary of the ribs on chest X-ray and bowing of the tibia. The Cartagena syndrome is characterized by infertility and situs invertus, coarctation of aorta with rib notching on chest X-ray, traumatic injury, traumatic fracture will be showing as a clear break of the tibia, and cerebral injury would be presented with ataxia rather than simply of unsteady gait. Here we have a table where we have the deficiency, 78 hydroxylase, 21 hydroxylase, and 11 beta hydroxylase, and we have aldosterone level, cortisol level on the left side, sex hormone levels, hypertensive or hypotensive, and sexual development for girls, for boys, and electrolyte abnormality. From here, the most important is are they hyper or hypotensive? 17, we need to notice that 17 hydroxylase is hypertensive, 21 hydroxylase is hypotensive due to salt wasting shock, and 11 beta hydroxylase is hypertensive. Thank you for your attention.